be discussing innovations today, and we'll have various presenters. Maybe we can put up that slide again for the presenter that you have today, so that we introduce them before we have our first presenter. Yes, so today we are going to have a discussion around innovations, and this will be our presenters today. We'll have Mr. Zakaria Kimengich, who will be taking us through the first session, and he'll be talking about some various innovations that he has done from the first innovation that they did on the hip spiker. They've had some others on board, and he's going to be taking us through that with Dr. Peter Kamau Njoroge, who's not able to be with us today. But maybe Zakaria, you'll introduce him further and your team further. Then we'll have innovation discussion around how we can improve our processes or innovate around our service delivery in the hospital, which will be presented by Dr. Mary Wayego, a neonatologist here in Kenyatta National Hospital. We'll also give her a chance to introduce herself further in the second presentation. And we have another very interesting presentation by Teresia Kabebe, who will be talking about one of the innovations they did in the medical wards, a simple innovation to reduce infection control. And so we'll have a very interesting session today. We welcome you all to take part in it. You can post your questions and your comments in the Q&A section, and we'll be able to have a discussion at the end of the sessions. So welcome you all. We can start now. And Dr. Karingo from Medical Research will be taking you through the moderation. I now welcome Zakaria Kimengich, a senior technologist, orthopedic technician in Kenyatta National Hospital. Welcome on board. Welcome, Zakaria.
Thank you, Karen. Good afternoon. You can hear me? Dr. Can you hear me?
Yes, we can.
Thank you very much. I'm Zakaria Kimengich, working at Kenyatta National Hospital. So allow me to take you through about innovation that we've come with some of the team in the hospital. Sorry for Takamau will not be there. He's in another meeting because of the hospital activity. So allow me to take you through about innovation that we came up in the hospital, the pediatrics hip spiker table with extension traction. We came up with Dr. Peter Kamau Njoroge, who is a consultant orthopedic surgeon. We have also a doctor called Dr. Doris Chomba, who is also a consultant orthopedic surgeon in the Kenyatta National Hospital. Can you see my slides? Dr. Can you see my slides?
Yes, we can see your slides.
Yeah, so that is the hospital where we are working. You can be able to see that. That is Kenyatta National Hospital at accident and emergency. So that is the photo of the hospital. Now, this is me together with Dr. I'm an orthopedic trauma technology with the passion of improving non-operative care in the country and even beyond. That is my passion. Dr. Kamau is a senior consultant, orthopedic consultant, who believes that affordable and effective orthopedic care should be available for all. So innovation in health, this is a big topic. It has a lot, but allow me to take you through a few innovations that we came up in the health. One is creative, innovative solution to a common challenges in health sector. So there are a lot of common challenges in health sector, whereby require a team to be able to come up with innovation. So definition for innovation: one, introduce new idea. So this is how you can define innovation: introducing a new idea. Another definition, something new. Another definition is new way of thinking. Also, turning an idea into a solution that add value from a customer perspective. Then coming up with idea in relatively, which is easy, cheap, and then those ideas need to be executed. So this is just a brief definition for innovation. Now, we have what is called invention. There is a difference between invention and innovation, whereby participants need to understand these different two things. When we say about invention, refers to occurrence of an idea, of a product or a process that has never been made before. That is called invention. It is something that no one has ever came up with it. So that is called invention. So if you come up with something that no one has ever come up with it, that is called invention. Now, about innovation now implies the implementation of idea for product or a process for the very first time, or adding value for something existing method or devices. So like now our innovation that we came up, we added some of this. This was an existing. We didn't have this hip spiker table, but the existing one, which even we don't have, we were able to improve it. So that is called innovation. So for innovation to happen, three things. So when anyone come up with innovation, three things must be there. One is called market with the need of a solution. Is there a market? Yes. If you come up with that, is there a market for that particular product you're coming up with? So that can be able to solve a solution. And we get this spiker table because market is there and the market is the hospital. So we're able to solve this problem of coming up with this product. Then technology that will enable the solution to be made. So we came up with this technology. Then business model that can create support, deliver and sustain delivery to solution to the market. So these are three things that anyone will be able to come up with the innovation. So allow me to introduce you the first hip spiker table that we came up. So pediatric hip spiker table is a specific medical devices which is used in a hospital to position a child who has sustained a broken bone of a thigh and hip fractures. So we came up with this table, and this table we didn't have in the hospital, and even most of these equipments are normally imported. So we came up with this. It is an equipment normally used to position the child or any patient who comes when the bone breaks. So therefore, the machine helps to align the bone, then spiker cast apply. So about the hip spiker table, this is a table or a machine that is normally used to position the baby, so that now we can now be able to align the bone, because we get a lot of patients who comes in the hospital, broken part of their bones, and if you don't have the right equipment, you may not be able to achieve this bone. So we came up with this hip spiker table so that can help us align the bone. Now, hip spiker table is just elsewhere. Where is this? To understand where do we the casting room or plaster room. So this is where the table basically normally there, because it's an outpatient whereby patients comes, we're able to align the bone and then put the spiker cast. So and then we're able to discharge this patient going home. So this hip spiker table is one in casting room or plaster room. Another place where this spiker table is orthopedic pediatrics ward. Pediatric orthopedic ward is where now children sometimes admitted. Maybe maybe some of these children were admitted because of other condition. So this table is very important in orthopedic pediatrics ward. Another place where this table is very important is theater, where our orthopedic surgeon normally do surgeries, or when they're doing procedure. You need to have this table so that you can now be able to position the child when they're doing the surgery. just like even the traction table. So pediatric hip spica table is very important in our hospital. Another place where this table is fracture clinic, very important. After now the patient be seen, they need also to be put in a fracture clinic. So who normally use this table? It's very important to ask ourselves, who normally use this hip spica table? One, we have orthopedic and trauma technician or technology. So I'm actually an orthopedic and trauma technology, where we used to be called plaster technician. Now that we are now able to change. So we are the guys in the hospital who really use this table. Another orthopedic surgeons who also use this table so that they can now be able to manage this pediatric table. So it's a very important table in our hospital. Now, working experience since when I got employed 2002, this came as a result of having worked for 20 years, managing and fixing fractures non-operative. I saw a challenge because of the tool being used that were not efficient and effective. So having worked for Kenyatta for 20 years, I saw a challenge because this is day to day. We normally fix fractures, we manipulate and put a cast. So we didn't have the right tool. Therefore, having seen this challenge, I went and shared this idea with Dr. Peter Kamau, as a surgeon. Then an idea came because it's a want to share this idea with Dr. Peter Kamau Joroge. And thereafter, Dr. told me, yeah, I think, Zach, we can be able to do a research and be able to design. So that is where by now we're able to design a hip spica table. So an idea came for hip spica table. That's why you can now be able to see. So having come up with this idea, you can be able to see that is Daktari together with me. We were now able to sit, how do we design and come up with a better hip spica so that we can now be able to manage most of the children. So teamwork and synergy is very important. Now, this is the hip spica table that we came up and be able to see it comprises so many things. Now, the massive problem, the problem that I saw, it is the shortening of the femur. You can be able to see this is the bone of the femur. That is where the bone that has already broken. So, and when the bone breaks, it is always a shortening. And when there is a shortening, you need to be able to align. And unless we have the right equipment or the right tool, we may not be able to align this bone. So that is where now the problem came. Because the problem to address this, one, poor alignment of bone. So before the hip spica table, or before this innovation, we were not able to align the bone. Another thing problem that also I saw was deformity and long-term disability. You see, if the bone is not aligned, there will be a deformity and there will be a long-term disability. Another problem, if bone is not aligned, there is an increase in pain during the spica cast. So because of that problem is unnecessary admission to the ward. So before the innovation, we were admitting a lot of children so that they can now be able to be admitted and even to be put on a traction, and the child has to be there for even 4, 6 weeks or even 8 weeks, which is very expensive. So where now the next point is high health cost of the family. You see, in this developing country, most of the people don't have the NHIF. So imagine the child is admitted for 4 to 6 weeks. Very expensive. How many parents can be able to afford? So those are some of the problems that we saw. Now, allow me to take you through. This is the various current method normally used in our hospital across 47 counties. You'll actually be surprised and be shocked. This is what is happening. So like now, this is a spica crest. When I joined KNH or Kenyatta National Hospital, this is what we were using it. It's called the spica crest. And the history was, we were using it, it was being used since 1950 by our first plaster technician. So you can imagine, It was incubated, brought to the hospital, and we continue using it. So this is also another, if you don't have that, you see, jerrycans are normally used, you need to be able to position because you don't have the right tool. So this is also one of the, another method normally used to position the child. It's very unfortunate, even now in most of the hospitals, they don't have the right equipment. Now, this is also another method normally used in the county hospital. There's a big problem in our hospital, and even after this default has been, after even the health has been devolved, there's still a lot of challenge. But I think now the counties are now improving, which we must appreciate. Some of the governors are working hard, and we encourage now that counties has been devolved actually to equip most of the hospitals so that they can now be able to manage most of the patients instead of referring to most of these referral hospitals. So these are some of the methods normally used in most of the hospital to position the child. You can actually be able to see. Now, this is also another method you can be able to see. These are some of the photos I'm normally being sent by the most of the hospitals across 47. See, this is a child is normally being lifted. You can imagine a child with a broken bone is being lifted, and then the spica cast is normally applied. Now, allow me to take you through the involvement of the process, how we came up with this hip spica table. 2015, after attending a training in Kijabi, I saw, you know, Kijabi is one of the hospitals that most of the orthopedic projects are normally done. So I saw one of the table there, I took a photo, and then came to the hospital and actually requested the hospital that they can actually fabricate. So thank you for the technical team who were able to fabricate this. So we were able to use in 2016 and 2015, 2016. Still, we saw there was still a challenge. So in 2017, now this is now whereby I and Dr. Kamau with a single, we now improved from a mild steel now to the stainless. Actually, this is what we came up. We were now to be able to improve. Now, came up with that. We were in 2018. So because this was single, and now in 2018 and 2019 we improved because it was, you know, as you continue using the table, you're able to see some gaps, and so those are some of the gaps we were able to see some gaps and even improve to more further to modify to now become what is called a double extension fraction to use with a child who had broken the thigh bone, treated to use this spica table. It's an amazing. We were able to align this bone. And actually, you can actually be able to see this is the femur or the thigh bone. After using the hip spica table, now you can actually appreciate the innovation that now we're able to align the bone. But ideally, this is as a child, so we've reduced the admission. So this is also another child. Okay, when we came, you know, 6 years old, most cases you admit this child. But because we had the table, you can actually be able to see this was a distal femur. And when you ask even any orthopedic surgeon, they will say, admit this child so that they can actually be able to put traction. And even some of the children end up being the innovation we came up, and you can appreciate the innovation actually we were able to reduce. So everybody was very happy to see now this innovation, this is
Hello, Zakar. Hello, Mr. Kimengich. Hello, we are not able to get you clearly.
Now, this is also another child. We have a child. Some of these students are came up with this hip spiker table. One, to avoid admission, social trauma, young, safe on ward charges, safe bed spaces for other conditions. Patient even is nursed in more comfortable at home. So these are some of the advantage for applying the hip spiker table over admitting this child, because we had the right equipment. Well, most of these children are admitted and are actually put on a skin traction. So this child has to be on a skin traction for 4 to 6 weeks or even 8 weeks, which is very expensive to some of their parents. Now, allow me to take you through the advantage of this pediatric hip spiker table or this innovation. So when we came up with this hip spiker table, one, we've reduced deformity because we are now able to align the bone, reduce the pain during the surgical procedures of the lower LV cost.
Hello, Mr. Hello.
Gone down.
Hello, Mr. KNH. Are you able to hear me?
Comfortable position of the patient. You can hear me?
No, we are not able to get you clearly. There's a lot of breakouts, and then you might need to get to the end of the presentation in time for the other presentations. We are not able to get you clearly.
You can hear me? Hello, you can hear me? Though?
Yes, now we.
You can hear me?
Yes, we can hear you. You can go ahead.
Okay, sorry. So I'm almost finishing. After I came up with this innovation, I managed to travel to UK, went to present for 2 weeks, and I was able to be given some support. And these are some of the hip spiker table we were able to donate when I came back from the UK. One, we were able to donate to Kenyatta National Hospital, the table that we are using it, Bagate County Hospital, Mama Lucy Hospital, Thika Hospital, Hijabi Kiwa Hospital, Kerogoya Hospital, and also we even donated to Dr. Rashid, who is now administration in the Ministry of Health. So now, these are other few innovations that we came up. Apart from the hip spiker table, we've also came up with what is called a scoliosis table. We've also came up with what's called wall hand sanitizer stand, hand wash station, and also there is also one we've came up just recently, ultrasound guiding fracture reduction. So this is also something that we came up in the hospital, and it is a study that actually we are using it now to be able to manage most of the fractures. So now this is a scoliosis table. You can actually be able to see, this is the another innovation that we came up. You can see the Dr. Kamau there. This is this is Dr. Chomba and also me, and that is one of the engineers that is working on it. Now, allow me to take you through, I'm actually finishing. This is the hip spiker table, which is in US. This is how they normally position the child. You can see that one. You can actually be able to see. Now, this is the one we came up. Now, the existing one does not have adjusted extension, does not have even, cannot be able to reduce the pain. It is very expensive to import some of these equipments and does not allow the footrest. So this is how the CEOs. Now, after coming up with this hip spiker table, I've been able to receive some few awards from CEO Kenyatta National Hospital, head of Department of Orthopedic Kenyatta National Hospital. I was also able to got an award from the Royal Academy of Engineering in London. That day, I was also been able to awarded a presidential award, and that is the Order of the Grand Warrior in Kenya. They got the first award. Now, this is when I was in UK. You can be able to see. You can be able to see that. Now, this is when I was in UK. We were able to meet with other innovators. This is one of the innovators from the Turkey and another one from the South Africa. I was able to manage the first position. Then, what is the way forward as I finish? Require mass production of this hip spiker table with the extension traction. training of the personnel on the use of this equipment, and also maintaining of this equipment. This is the way forward. And we humble request the government through the Ministry of Health to support the innovation of this spiker table, to adopt this innovation in equipping our facilities with the right equipment as an effort towards the universal health care and a big agenda for the government, targeting public and private hospitals in the country. So allow me to acknowledge KNH management for the support, head of department of orthopedic trauma team, my colleagues, technical team in Kenyatta Hospital, and most of all, Dr. Peter Kamau Njoroge for his mentorship and innovative mind. So lastly, become a solution to a problem. Thank you. Thank you, Dr.
Very much for that, Mr. Zachariah Mengich. It's indeed been a very, yes, it's indeed been a very insightful presentation, and thanks for keeping on and for giving that presentation. We are now going to our second presentation, whereby we are going to we are going to discuss on innovation in a process innovation. Just as Mr. Zachariah said, innovation is about the creation, development, and implementation of a new product, process, or service. So we are going to change gear and look at the introduction different introduction of processes, new processes or new ways of doing things that enhance service delivery, which is going to be presented by Dr. Mary Wayego, who is a neonatologist here at Kenyatta National Hospital, has done a lot of work in the unit, in the NBU unit. They have done a lot of changes in just trying to reduce infections in the unit. And so we are going to see some of the things that have been done. So for any questions and comments, please put them in the Q&A section and we'll be able to get to them. Thank you. Karibu Daftari.
Thank you, Dr. Karingo. I'm going to take us through a presentation on what we are doing in the newborn unit to improve quality. And like we've learned that innovation is adding value to an existing method and bringing on ideas that can improve processes. So what led to these process of quality improvement from a group of us is we've been having a lot of outbreaks in the newborn units of very resistant bugs, and we had an introspection to see what can we do that is within our reach to help get these infections low. It's very easy to pass the buck most of the time and say, you know, we need big units, we need many other things. But what we thought about is what can we do as we wait for those other big things to come and help as we are already on the ground. So first, we thought about what exactly is ailing the newborn unit. What can we do with what is available at hand and with the expertise that we have? What are the priorities? And what do we do about those priorities? So first things first, we had to come up with a team, and many times we have had teams that, you know, are composed of people in isolation a lot of times. So we'll have a team that has doctors and residents and fellows and nurses on the other side, have their own group and have their own processes. So what we thought about in this solution is to have a group of like-minded people from all stakeholders that are part of the solution in the newborn units and experience that problem, and come up with ways of making it a reality for everybody. The team members that we looked at, and within any group, you have different characteristics of the workers that we work with. But what we are thinking about is from the team members that are in the entire team, who might be motivated towards making changes, who has demonstrated leadership skills, who is more available. Some people in the team might have other engagements, for example, might be in school or have other issues that might distract them, and who is willing to be part of the team. And the team had to be multidisciplinary, like I've said, because we want to have everyone that is part of the unit and part of the team and bring in their ideas on bringing change. So the team has consultants, it has residents, and usually the resident team leader at any one time is part of the group. We have some nursing staff, and each of the representatives has something that they're bringing on board in terms of their strengths. So we have teams that have a lot of interest in equipment. We have staff that have a lot of interest in mother education. So we bring all those on board. We also bring in members from the rest of the committees in the hospital. So for example, we might have biomedical engineers co-opted when we have an issue that needs that expertise. We have people from quality, we have people from IPC, the hospital IPC committee. We also, so we have all those that are going to help with improving the processes. So we strategized and said that the way we would take this forward is to have accountability and a way of monitoring. So we have monthly meetings, and in these monthly meetings, we will have assigned each of the team members tasks and roles that they need to play in the improvement processes. And then they report on, and we keep track of what we've decided to go ahead and do and how far we've come. Each individuals motivate themselves to go ahead and do what they've been allocated. And they'll report back and tell us what worked, what didn't work, and what we need to do and improve and make it easier for them. So we prioritized as a team, and so that the biggest issue we had at that point was infection. So we had to look at ways of doing infection prevention and control. We also realized that there was part of what was ailing the unit was communication and teamwork, so that everyone did their thing, and there wasn't much interactions in terms of making the process as a combined effort as possible. The other priority was introducing preterm care bundles, because we realized that most of our babies and most of our mortalities are coming from the preterm babies. We also brought in the issue of doing constant morbidity and mortality. Those were already ongoing, but now we encompass this in the processes of quality improvement to just make sure that everyone is working towards the same goal. So I will just go through what we did with IPC. So we recognize that there are many points within the unit and without that contributes to infection introduction within the unit. And some of this might be beyond our ability. So for example, having a big isolation room will require maybe breaking down of walls, creating more space. And at that point in time, we needed to act, and we still need to continue acting as we wait for that larger project. So for IPC, what we found to be within our reach was the improvement on our hand hygiene compliance and reducing the culture positivity rates from the babies that get admitted with a diagnosis of sepsis. So what did we do? we set targets on where we wanted to come from and where we wanted to get with the hand hygiene compliance rates. So we picked up the WHO tool on the hand hygiene compliance and adapted it to our setting and had a baseline assessment, and then we'd continue looking at how rates go. I must admit that this has been an up and down, but we are not where we began. It's still work in process. So that's one of the things. The other thing that we did in terms of monitoring change is documentation. So we created a file that has this, and we constantly look at it and see the areas that are notorious and focus on those. And then we also are tracking the blood culture positivity rate. So we are working with the lab personnel for them to flag those blood cultures well in advance before the paperwork gets to the unit, so that we can act sooner. So at the entrance, now this is IPC, at the entrance, we realized that security and controls in terms of who gets in has been a big issue, and hand hygiene at the entries has also been a big issue. So this is work in progress in terms of providing hand wash basin at the entry, and it's that's what now is beyond our ability, but it's been flagged and handed over to the right department. But we worked with the security to ensure that we provide a hand sanitizer and ensure that the security are actually keen to check that, excuse me, the moms coming in or other people coming into the unit do sanitize at the entrance. So that is what we are doing at the entrance. And this, again, we have realized that we have to keep doing this because the guards that are at the entrance might keep changing. So we worked to have one consistent one, but that is not always guaranteed because of the nature of their contract. So we have to keep them on abreast on what needs to happen on the people coming into the unit. And then we also realize that we have to work very closely with the moms. So each individual within each room, each nurse heading a room, for example, the team leader in each room had to come up with ways of educating these mothers, considering that we have different at any one time. Of course, we have those long stay ones, but we have those that keep coming and moving rooms. So having to have that health talk on the moms, and we have actually came up with talking points so that it's a very simplified and direct message on the importance of hand hygiene to the moms. We also work on early diagnosis so that we institute appropriate management and discharge early enough and minimize overcrowding. We have it's still a problem for Kenyatta Hospital newborn unit because we have very many babies and it passes our capacity, but these are some of the measures we've done. Still pending is the issue of down referral. I mentioned that we've been working with microbiology department. So how we worked with microbiology department in terms of reducing our culture positivity rates and also making the processes efficient is proper training on specimen collection techniques, so that what we get is something that we know that is unlikely to be a contaminated positive culture. And this has happened through training on specimen collection. And we're actually in the process of developing a video for learning, for distribution and for learning. We realize that when we try to look for that information in the media and in the internet, there's hardly actually much around the newborn specimen collection. So that is also work in progress. We also have instituted a way of monitoring the pigeonhole so that samples are taken to the lab promptly and do not lie there longer than is necessary. We also have a follow-up phone call and a flagging of positive lab tests from the microbiology department. And once we confirm positive cases, we isolate and cohort these cases together. And we also are working very hard to make sure that all babies coming into the unit at the point of contact in the admission room have their cultures taken at that point, so that we pick the sepsis quite early, we identify the bugs quite early, and we get to cohort these babies quite early before spread to the neighboring babies. So again, to just minimize this counter contamination between rooms, each of the people manning the rooms stock their rooms so that there is no inter-room, moving around to pick supplies. Use of trays to just so that as the doctors or the nurses taking care of the babies and doing procedures, they don't have to shift between rooms and between beds to pick things. So things are collected in one place and a procedure is, I know this is something that should be happening, but until it's re-emphasized, then it dies down. We also have worked very hard together with the IPC department and the supplies to ensure that we have sanitizers by the bed, so that the sanitizers are there looking at people taking care of the babies. So it's easier for them to just sanitize before moving to the next babies. We've also created a way of limiting the number of students within at any one time by creating rotations and shifts. So like for the medical students, we have some coming in the morning, some coming in the afternoon, and shifting around so that they get the exposure, but also whilst minimizing overcrowding. And we've also worked very closely with the nursing standards to help us with the control of the number of students coming in. So they're distributed properly around the year, so that we don't have times where we have much more nurses than we have space for. We've also introduced an induction package, so that before we have residents and medical students and nursing students coming into the unit, they need to go through the WHO IPC course. This is a basic course, but in addition to the information and knowledge that it provides to these people coming to rotate in the newborn unit, it also emphasizes how important IPC is for the unit. Student reorganization, I've spoken about that. Again, I've also spoken about room reorganization. So what have we found? We'll be presenting this information at some point as we do our analysis and as we continue improving on the processes. But generally, we've had reduced culture positivity rates. We've had improvement on hand hygiene compliance, and there's generally an awareness on how important IPC is in terms of reducing our mortalities, our crowding within the unit. And there's also an awareness on individuals that there's something that each person can do within something that is within their capabilities and within their reach, without necessarily waiting, for more resources to be availed. Yet we have not made complete use of what is within our reach. So we still have to get usable bins so that we just keep improving our hand hygiene compliance rate, so that as people wash their hands and dry their hands, there's somewhere to throw in the bin without contacting, without recontaminating themselves. We are also working at ensuring that we have a way of crowd control at the entry so that we have less people that get into the unit. We are also working with the IPC and quality department to make hand towel availability more consistent. And we've also presented our proposal and need for a bigger isolation for isolating and cohorting babies that have been found to be culture positive. So that is just a small one of the ways that we are trying to work around improving our sepsis rates within the newborn units. There's still much more that is in store and in plan, but this is the beginning of what we plan to do as the year goes along. Thank you for your attention.
Thank you very much, Dr. Oyego, for that presentation, and just an innovation around innovation in the healthcare sector and what we can do to improve our processes to enhance patient outcomes, and that's really good. And this is was just one of the encouragements that innovation doesn't have to be that big thing that you do, that new product or new way. It can be these small steps that you take within our various units to improve care, and that is what really matters. We are now going to go on to another presentation by Teresia Kabebe. She's one of the nurses working in Kenyatta National Hospital, and they have worked together as a team to also come up with a small an innovation to be able to enable them to reduce infections in their units. Karibu sana, you can take it up.
Good afternoon, everyone. I'm Teresia. I'm working with 7B. As we continue with this topic of innovation, or to better our care to our patients, 7B is a new award where we have identified one item to improve, because you said the innovation, you can actually innovate or you can better the equipment that you have. As we actually identified a gap in our trolleys that we use in the ward, that's why we have a Jikinge Rahisi trolley that we have been working on as a team, as a ward, to enable us to be able to give our proper care, taking care of the IPC, taking care of our clients and the staff members and all the medical staff in our department. Our innovation is all about the trolley that we have actually tried to modify as a ward. And this medicine, we can go up. We can continue. Keeping with our vision of the hospital, our world-class patient-centered specialty care, we realized that there was a gap in this one of procedure trolleys that we use in the ward. Our mission also to optimize patient experience through innovation, healthcare, facilitate training and research, and participate in the national health policy. Actually, our innovation is around our know about our motto, design and care. Okay, we can continue. And the innovation was actually initiated in Ward 7B, was actually innovated in Ward 7B, that's medicine department, to enhance infection and control, prevention measures, with aligning in our policy of IPC. The innovation was well adapted in the ward. The same innovation was extended to other wards, as we'll see as we go on. In other wards, department, that we started our innovation in 2017. That is the first quarter of the year. And we're looking forward in the second and the third quarter of the year to be extended to other wards, specifically infection, orthopedic, and surgery. For most of us who talk Kiswahili, Jikinge Rahisi is a procedure trolley modified to enhance infection control and prevention. Jikinge is a Swahili word meaning protection. Where we modifying these trolleys to modify so that it can be able to protect us from infection, from injuries, to our client, to the internal and external client. The trolley is modified to facilitate protection to caregivers, that is the medical team and the client. Rahisi, as we call our trolley as Jikinge Rahisi, it's also a Kiswahili word meaning easy, which when we say easy, what exactly do we mean? It's easy in terms of setting and demonstration. Remember, in our hospital setup, we get turnovers, student, medical student, nursing student, medical student, orthopedic, other people who come around to do their experience. Kenyatta being a training center, it is easy to show them how to do it and demonstrate. The other thing why I say it is because it is cheap. You don't need to, for innovators, they go for, they don't go for very expensive experience. It is cheap, no cost complication as the hooks, because this trolley actually, what we have modified it is just a normal trolley, and then we are trying to make sure that we have some hooks on it. So we will be seeing it as we go along. We will demonstrate how it looks like. Hooks are obtained from the holders of obsolete gifts. So that is our materials which are readily available. These are the things that we usually condemn in the ward and put them back to the maintenance department. Some discarded metals at the maintenance department. Continue. The objectives of the department, as we came up with this innovation, was to enhance clinical governance by promoting technical geared toward the preventing and controlling of infection, IPC. Remember, in a hospital, we have to, as our previous presenter at the panelist was talking about, she was really insisting on the infection control, especially to the children. This also happened to the adults. And for us to be able to minimize this or control, infection control, it's what geared us to come in this innovation. Linking the innovation to the strategic plan, the hospital strategic plan encourages the staffs to be more innovative and creative. The innovation captures the mission of the hospital, which optimizes the patient experience through innovation. Which model do you want to use to disseminate this information? Through our continuous progress development, that is like the CMEs. We've taught this innovation in our CEOs forum and our grad in nursing round. As we are doing our grad nursing round, we talk about it. Area of replication, imagine that all the clinical areas in Kenyatta, they use trolleys. Like 80%, apart from maybe the offices, the human resource, but most of the clinical areas use these trolleys, and they need to be modified so that they can actually be able to serve our need and be able to prevent infection from spreading. Customer affected by the innovation are the patient, the internal and the external customers. These are clients who we take care of every day. These are our patients. Client, the people who come to see our patients, their visitors. Where was their drive for this innovation? Is it justified? I think so, it was, and it is. The innovation was a result of the gap identified. The highlight captured below are for Ward 7B, which serve as an example of all the clinical areas. These are the gaps that we saw, and that is why we came up with this innovation. One was the resource wastage. For those who work in the clinical area, they will bear with me. And before we started using the hooks on our trolley, we used to use strapping to secure the ringer bags on the trolley family. because these trolleys did not have hooks as they have now. Because you need to make sure that as we're going to the bedside, you have your trolley with the liner bag so that you can be able to use your waste, segregate, and dispose. You want to use that trolley which doesn't have it. There was a gap. Use of surgical braid to cut off the strapping tied on the liner bags after use. You see, we are wasting a strapping, we are wasting a surgical braid. The next photo highlights how the strapping is used to fix the liner bag on the trolley, leading to strapping with stitch. You can see my colleague there. This is my ward 7B. These are my colleagues. You can see one of my colleagues actually trying to strap the liner bag on that trolley, because we have to use the liner bag so that we can be able to segregate the waste. This is how wastage it was. After we strap, imagine you have to remove it now because it will stick. We have to remove it with a surgical blade. So there was a lot of wastage of resources. Continue. Because these trolleys don't have hooks, and not everyone in the world who is have the time or did have the time to hang the liner bag with a strapping. Some of us, the clinician, the nurses, the students, will tend to use the trolley without the liner bags, leading to poor management of waste. Some of clinicians preferred moving with the trolley without the liner bags, leading to a mixture of. You can see at the down shelf, there's a lot of mixture of the waste. Remember, the policy of IPC says use, segregate, dispose. Remember, when you mix them like that, you end up going somewhere to the dustbin and start sorting them out. That's not the policy of IPC. IPC is use, segregate, dispose. So that is number 3. There was risk of injuries and infection. Due to lack of easy way of disposal, some clinicians would forget needles on the patient's bed, which could injure patient, medical staff, and even external clients unknowingly. This is very common, and I think we have been, personally have been a victim. I have ever been pricked a needle which was in the patient's bed. Whoever left it, you don't know. And it's actually a rampant incidence in the hospital. We're always going to repeat the needle prick. You're put on PEP. This is not the best thing to experience, especially. So because imagine they are trying to put a blanket or put a cannula, and they don't have the safety boots. They tend to put, by the time they are strapping the blanket, they leave the needles on the patient's bed or the gloves. Unknowingly, probably sometimes not even they are not even conscious about it, because they don't. No one of us want to hurt our colleague. So the risk of injury is very high, depending on the nature of the disease of the patient involved. You can imagine the patient had HIV or hepatitis. There always that percentage where you can actually be contaminated. When the clinician uses a trolley without a liner bag, and when I say clinician, I don't mean the doctors, I don't mean the clinicals, I mean like the medical team. I use a trolley without a liner bag in a sharp container. He or he tends to put the wrist on the lower shelf of the trolley when moving through the same trolley from one area to the other. Some of the waste could fall down on the floor, becoming a source of injury. That is very common when you walk in the ward. You can find a glass on the floor. Probably it wasn't even deliberate. It was maybe by mistake. I did not even realize. The following picture, you see how those wastes spill off from the lower shelf of the trolley accidentally, and then you start picking them up. This is now, if you, there was a hook where we can do the liner bag. You put all your waste in the liner bag. After that, when dispose, you can't get some scenario. Before we actually came up with this innovation, we actually had a lot of strange relationship on the floor. Like what you can see on the is a public health staff actually coming with gloves they have collected on the floor, and actually showing to my boss, which is Mr. Mogi, that this one was, we cleaned the ward, and we are still putting this on the floor. You can appreciate that ward is very clean. It is very, very clean. Our public health staff are doing a good job. But accidentally, because the trolleys that we're using are not clinically friendly, make their work actually difficult. Comments from other caregivers on finding used needles, syringes, gloves left on the patient's bed. That one I went on it, I spoke on it. Occasionally, some clinicians forget to dispose the whole load of waste on the trolley after use, becoming a burden to the next use of the team leader. Remember, you can't be called and you go, maybe you're running to a class, you're running to go and maybe attend to another patient, you're running to go for blood for a patient, and then you forget to clear your trolley. Imagine it's become a burden for the next user to come and sort it out. As we still able to follow the IPC guidelines, you're supposed to use, segregate and dispose. So no one should come and dispose the waste. The other justification was the time wasted, a lot of movement from to and fro to designated area of waste disposal. Imagine you're doing an injection, you're giving injection in the way, and your trolley is not friendly. That means you'll be giving one, you'll be doing a procedure, come dispose, go back. You waste a lot of time because of to and fro. But our improved trolley will actually going to sort our mess up. This innovation had to be thought, had to be identified. Innovation process took us 7 steps. Problem identification. The problem was identified by most of us in the board. That was our staff in Ward 7B, who we are this is our baby brain innovation. But it has now not been a baby brain 7B. No, it has really disseminated to other wards and other departments. Idea generation, the idea was established through brainstorming. In our morning meeting, we could, like after the report, we'd sit down and decide and talk about it. How can we do it better? How can we improve our working environment? The innovation process number 3 was consultation with the maintenance of this, how, because now when we came up with the idea of putting hooks on the trolley, we had now to make sure that the maintenance department is on board, and so the concept was shared with the organization, that is putting the hooks. Remember, we said this innovation wasn't very expensive because we are using the obsolete drip studs. If you go to the maintenance, you find so many metals which are discarded there, small ones, and those are the things that we used. So we had to bring them on board. We had even to go there for, please go back. We even to go there and see exactly what they were doing. Next time we need to go back. Yes. For them to do their work, we have to we have to actually to fill a form for them and ask our messenger, one of whoever you're seeing in the office, the boss, and pushing the trolley is a messenger in the trolley. There's a form called E1 in the hospital that you have to actually to fill in and send the trolley with it to the maintenance. Continue. So in the maintenance, this is one of our staff who work in the maintenance. You can see fixation of the hooks, the procedure trolley fixed to the hooks on the 3 different corners. On the top shelf, 2 hooks to hold the liner bag. So that means 2 hooks are being done on one side, and the other one is done on the other side to hold the sharp containers. So that's the one of the staff doing the welding in the maintenance department. After they said it was complete, it was time for us to go and correct it. Correction of the modified procedure to the ward. We had to go ourselves and see whether the right thing was done, whether there's something else we need to modify. And we were certified with the work because we had shared the concept with them, and they did a perfect job. That is one of us going to the maintenance department to correct the trolley. In the other picture, you can see our messenger bringing the trolley back to the board. We have to sensitization or demonstration to the clinician and the nurses on how to fix the liner bag and the sharp containers. I believe most of you have seen this, and this is now what the 2 hooks that is hanging the liner bag and the sharp containers. You can see one of us doing it very comfortably. Yes. And now that become friendly for us to use it. You can tell, did we have challenges? Yes, we did have challenges going through this procedure and through this innovation. Culture change. People tend to forget, requiring constant reminding. You'll see someone forget that trolley has hooks. You need to hang the liner bag. You need to carry the safety box with us as we're doing our procedures, especially when we're doing bloods, we're giving medication, we are doing condition. You have to carry the trolley and carry everything that requires. A clinician turnover, frequent changes of doctors, clinical officers, students, requirement are last for a month. So you imagine that we have to keep on reminding them or training them on how to use this trolley until it has been modified for this work. Yes. Shortages is one of the challenges that we have actually faced. In the world of 60 patients, you can find yourself having like 3 trolleys. Imagine like in the morning, you have so many procedures going on. You're dressing, you're doing medication, there's a major ward round, people are doing blood. With like 3 trolleys in the ward, it is not easy. So there are few procedure trolleys in the ward. Other alternatives, which mean not to uphold the concept, come into play. You can see a clinician putting gloves in their pocket, which is not an IPC procedure in the IPC policy. So we have actually tried to work with the budget department to make sure that we have enough trolleys. What were the positive outcomes? The concept was readily adopted, and everyone appreciated our innovation. You can see, it's hard now to see staff in the Ward 7B and the neighboring wards using the trolley without the liner bag and the safety box, because it is conducive and it is friendly at the end of the day. There is appropriate segregation of waste due to availability of the inner bags and the sharp container on the side of the modified trolley. Remember, we said the IPC policy is use, segregate, and dispose. Elimination of cross infection and injuries. Actually, I would report categorically that the needle pricks have really reduced. It's not easy to get used glove on the patient's bed. Our environment is clean, very, very clean and conducive, because you would hardly see a glove on the floor. Continue. Health relationship among the staff has really improved. We've been working very well with the public health staff. No complaints from the caregivers, external clients, and the public health team.
Yes, have we lost you? You're not able to hear you. Tasha?
Yeah, I'm back. I think my internet is not very stable. I was talking about the health relationship among the staff has really improved. Our public health team is very happy with us because the environment is very clean. Use of our resources well. The surgical bed and modification of the trolley because now they have the fluids. Continue. What are our recommendations? Adaptation of the innovation in the hospital, in the hospital. Impact assessment in the pilot and 4D, as we demonstrate as we go along. They have really adapted the innovation very well. They are actually giving the report to us. Our other recommendation is the purchase of future trolleys to adapt the similar model. Actually, it should be a trolley model. The purchase of more trolleys to supplement the few available, which are inadequate. Remember, we said one of our challenges is shortage of trolleys in the ward. Others just can view the trolleys in the ward 7B. The picture below belongs to ward 4D. Because now we have extended the innovation to other clinical areas. That is ward 4D. You can see how well they have done theirs and how the trolley is well presented and clean. What are our remarks? I commended the use of the King trolley, citing the similar advantage as for 7B. As you said, as I highlighted before, the challenges are our very few trolleys in the world, but the vision of the hospital that be able to purchase more. Our strongest recommendation was they should buy a trolley that is King type, so that we also don't do too much modification. So when they are being bought, that's our strongest recommendation. We can modify the one we have, but for future, they should buy a King trolley. That's a picture of ward 6C, as they also adapted the innovation. Yes. Let's tell you that the information is passing very fast. People are actually very grateful. That's still ward 6C. they are very grateful, and but the hospital need to do something. The sperm recommended base of the chicken get raised made 7 big. Continue. Go on. Innovation, stability, sensibility. We have actually working with the staff training center. The continuous training of both staff and the students on the importance and how to use it. In our conclusion, we need to have a clear roadmap on to be established between the nursing and the maintenance department to ensure all the procedure trolleys are fixed with the hooks. And for the hospital, for the future purchase of the procedure trolley, they should be of the Kinge model. I think I have a recap, Nelson.
Thanks, Teresa. You're saying you have one more? Yes. Thank you very much for that presentation and for the innovation that you've mentioned in the words on how to prevent invention. And we really want to thank our presenters. We had Mr. Zakaria Kimengi to give us the hip spiker and some of other innovations that we are looking at in the orthopedics. We had Dr. Mary Wayego with a lot of process improvements in the newborn unit. And now we've just had a presentation by Teresia, who's on an innovation that they've done in the medical wards to try and reduce the infection rates. And it has been a learning session that we were trying to demystify the aspect of innovation, that it doesn't have to be this big or expensive. Actually, these measures that have been presented here have been very small measures going forward that have improved the outcome of the patients, that have improved the satisfaction of the people working in those areas. And so it doesn't have to be expensive or a big thing, but it's about seeing what has come out across all the presentation is about seeing a problem. You see a problem and you see how to fix it. So remember, like in Mr. Kimengi's presentation, where he was mentioning that, yeah, he had been using this for the last 20 years or so, and he had been using the same thing and seeing that no, it is not as effective. And they came up with an idea and they brainstormed and came up with a hip spiker and all that went into it. So it's about continuous change, not settling, and also the teamwork. I hope we've been able to see that in all the presentation, there's been a lot of collaboration to be able to have these things in place and going even beyond. Like in the Kinge trolley that has just been presented, they went beyond and came out of the unit, went and talked to the people at maintenance to make them trolleys that suit their innovation and their needs. And that was really commendable. In the newborn unit, they went out of their way to talk to the people in the lab. They went out of their way to talk to the students. They even went to the watchmen for the unit, the watch people for the unit, and told them that it's important for people when guests come in, they need to wash their hands. So there was that initiative of going out of the comfort zone to make things better. And that's what we are talking about, that it's just about making things better where we are. We are now going to go into some of the comments and some of the questions and the comments in the section. Let us see, from Caroline Asundwa, the hip spiker table is age specific. Not sure if a comment or a question, but you can comment on that, Mr. Kimengich, as you answer the question on fracture femur 1 month old, what next? Go ahead, Mr. Kimengich.
Yeah, thank you very much. You can hear me, Dr.
Yes, we can.
Yeah, about the hip spiker table age, before the innovation, basically it used to be 3 years. You can hear me?
Yes, we can.
Yeah, before the innovation, what we used to do, when a child breaks the bone, the recommendation was just 3 years, you put a hip spiker table, then you discharge. But above the 3 years, then you need to admit. But now with the innovation, we are now able to manage patients even until 5 years. So now the innovation has really been able to improve. Another question is, I've seen it about fracture femur in 1 old month. Yeah, we manage that one, even if it's from even 1 day. A child has been born now, even like now, what we normally been, what we normally done at the casualty when a child is born at maybe in the newborn or even nursery, and it happens the break part of the femur. So what we normally do, we put the hip spiker day from day 1. So we normally fix the hip spiker table, hip spiker cast to any child who has sustained a fracture femur. I've also seen another one question. Can this hip spiker table traction be used in children with congenital problem? Yes, this table is very important, very important. Remember our orthopedic surgeon, when they go into theater, without this table, they cannot be able to really position this child and be able to reduce these congenital deformities in children. Yeah, so it's very important, even in terms of this congenital problem. This table is very important.
Thank you for those comments, and thank you, participants. We are seeing a lot of congratulatory messages to the presenters, saying these are very wonderful presentations, and we really do appreciate you joining us and for participating in this. A question here from Penina Thumbi. Thank you, Dr. Wayego. Beautiful improvement efforts. Do you think the COVID protocols added value to your efforts?
Thank you for the question. Yes, indeed. That's one of the positives that we are learning from, where we are getting from COVID, the fact that hand hygiene has become commonplace. But even despite that, we still realize that we still needed to emphasize this even more. So it helped because there's more awareness, but we still have to do a lot of emphasis and policing and making sure that the processes are ongoing. Thank you.
Thank you for that. And then another question here also for you. And before we hear from Teresia, for both NBU and the trolley innovation, we have the current infection rates to enable you determine the effect of the innovation later. So maybe a question on how are we able to determine the effect, or if there are measures in place to do that later on?
Yeah, we actually do have ongoing data collection within NBU in the clinical information network that is available in some hospitals in Kenya. So we have ongoing data collection. So because this has been a short time, so we will in due course analyze. We have baseline, and we will in due course analyze and see how this has impacted our sepsis rates. And that, you know, I'm sure it's going to be presented in one of these forums. Thank you.
Oh, that's really great. That's really great, because yeah, that's really great. So we can be able to see the measurement and see what effect it has. Maybe a comment from you, Teresa.
There's someone who have asked about the Kerry Jones. Have said the work on the trolley is good. How would we determine that we have minimized the cross infection? For instance, I would say for the last 2 years, we have not reported any needle prick, either left on the patient's bed or maybe on the floor, even from our public health staffs. That is one of the ways that we're able to measure that the cross infection has really minimized. The reported ones, I would say, but for the last 2 years in the world, we have not reported any needle prick. The other ones about the patients, whether we have been able to do more cultures to see whether they actually, whether we are cross-infecting to the patient. I would say it's random. It is random done. It could be 1 to 10 patients. 1 patient into 10, that is really minimized and very low. So we are still work in progress that we really need to monitor very closely. And but we are glad that everyone is appreciate our innovation, and we are willing to actually help other people do it. But according to the response I've seen, most of the departments have actually adapted the trolley. It's a work in progress. Let us work together and let us see whether we, especially the IPC department as a unit, they can also come in and help us to be able also to screen even for the very good unit. Thank you so much.
Thank you so much. Indeed, a lot of comments here saying, yeah, that's good work. That's really a good work and should be also disseminated to the other departments and even the other hospital. It's really, yeah, it's mind-boggling the way it can be. It's just a simple idea that has been able to have such an effect, and we really do appreciate that. And that's what we are encouraging actually. Yeah. We all there's one comment here I wanted to read out here from Dr. Dawa. Thank you for this innovative webinar. It has encouraged me to wear my creative hat often, albeit in a small way. So yes, it's all about continuous change and continuous improvement. And as we said, even for the during the presentation, that even right now, as we have done this, it's still continuing to see whether it has an effect, to see what can be done better, what can be done even beyond the Jikinge trolley. To make it even better and to make all our processes better. There's something small that can be done in all our areas of work to make things better, to make things more efficient. And that's what we are encouraging that's what we are encouraging, and kudos to the team. So don't think I've missed any. What are the incentives or motivations from the to management of those institutions? Yeah, there's been some incentives. Recently we had a call for innovation. So we had a call out for innovation, Kenyatta National Hospital Innovation Fund, and we were requesting, actually in the call, I actually have it open. Let me just read it, what it was saying. Yeah, it was requesting for innovation in all the areas, including process innovation. And actually the what we read out as the definition for innovation is in the website, stating that we need innovations in all areas, either product or processes, to enhance service delivery and enhance quality of care. So there has been that incentive, and to encourage people to apply for this funding as a department, as a unit, so that it can be able to have to get this work to be done. For example, if it's in the Jikinge trolley, with this small funding, you can be able to get more trolleys or something like that to help the department in the innovations. So there has been that start, and it's just a beginning. And we are going to get better and better now that we have started with these talks and encouraging more innovation, to be more innovation in the hospital. So we do encourage, even for the others in the other county hospital, please take it up in a small way. It does have a big impact. I think we've now come to the end of this session. I'll just allow final comments from our presenters. We can start just final comments on our presenter. Maybe Zach, you can give your final comment, and then Teresia, you can go next.
Thank you very much for this team, for inviting us. I, Dr. Kamau, and the team. We are actually developing a proposal to assess the efficiency of the hip spiker table in management of the fractures in this hospital that actually we donated this hip spiker table. So we are doing a proposal by we actually been helped by the Kevin Wangira and Nyongeza, with statisticians and the research in Kenyatta, is helping us a lot on that. So we are actually proposing that. And my recommendation is that all hospitals in this country to actually be able to have this table, so that to reduce referrals being referred to other patients, because when a bone breaks, it's very painful to be transporting this patient to one point to another one. Like now, we donated this table to within the hospital, like Mama Lucy, Magadi, and Thika. So they've actually reduced now referral to KNH. So I recommend all hospitals in this country across to be able to have this table so that they can actually be able to manage and to reduce admission and referrals in the hospital, and they cannot be able to manage these patients, these children well. So it's possible. I just recommend, because this equipment now is available, it's affordable, it's accessible, it's even more better. Actually, when you saw in my slide, we've actually improved it and modified more better than the one in US. So we have a better product. Buy Kenya, build Kenya. That is my recommendation. And actually, our leaders to be able to support the innovation in this country. There's a lot we can be able to do, even in our hospital. Thank you for that trolley innovation. I think a lot can be done on that. I think we were just discussing the other day that we need to maybe have a group for the hospital innovators so that we can actually be able to discuss how we can be able to improve our services in the hospital. Thank you very much.
Thank you so much, Dr. Karigo and the KNH Research Unit for giving me a chance to actually present. I'm very grateful for the department for even being able to, because I was not even able to project my work. Thank you so much. I feel so supported from your side. It is an innovation, and we are looking forward for everyone to adopt it, but I'm very happy to hear everyone is very happy about it. It is our duty as KNH staff to make sure that first we are safe and our colleagues are also safe. So I'm very glad to have shared our idea to you. Thank you so much. We're looking forward to being invited another time. Maybe even another event, and we'll be looking forward to actually share. I've also learned a lot from the Mr. Zakaria and Dr. Diego. It seems that everyone in Kenyatta is doing something which is geared to our mission, that we should be a world-class hospital. Thank you so much for the invite. I feel humbled to be part of the panelist. Thank you.
Thank you very much. Dr. Wayego has set out for another meeting, but in her absence, we really do appreciate her presentation and the work that is ongoing in the newborn unit. So we've come to the end of this session. We do appreciate you, also our participants, for staying with us till the end, for your participation in the questions and the comments, and for your encouragement to the team. We really do appreciate you. So we do welcome you for even our other sessions that will be coming up. We'll communicate, and yeah, let's go out and innovate. Thank you very much. Do have a lovely afternoon.
Thank you. You too, my dear.